without further ado, yeah, Dr. John Ndomi was supposed to be the moderator for this session. Unfortunately, not because of coronavirus, but because of a family health issue, he was unable to attend. So I'll assume the role of moderating this session and introduce myself, which Loth has already done. So let's go ahead and get started. The purpose of this, could I get the presentation up, please? The purpose of this particular talk is really just to give the introduction. This really is the introduction to the summit. This is why, this is the talk that I often give throughout the country as to why what we need to do. And so this is essentially an overview of what I view as the current status of gastric cancer in the United States. And so we'll be discussing a bit in very simplistic terms. Other speakers will talk in much more detail about demographics of gastric cancer, and this is all pertaining to the U.S. Gastric intestinal metaplasia, which is extremely well misunderstood in the United States. The concept of gastric cancer screening in the United States, which is extremely foreign in the United States, and then the management of early gastric cancer, discussing endoscopic resection versus surgery, which is a rapidly evolving area in the United States. So I like to start off with this and compare gastric cancer with esophageal cancer. So esophageal cancer, if you go to GI meetings, I mean, Barrett's esophagus is a major topic at all GI meetings. It gets, and I didn't do the research, but it gets, millions and millions of dollars of NIH funding and research. We have guidelines from the AGA, ASGE, the ACG on what to do with Barrett's, how to screen. And if you look at these numbers, one would think that this would be esophageal cancer. We'd think that esophageal cancer is much more prominent in the United States than gastric cancer because of the attention it receives. But if you look at it, it's actually flipped. There's 10,000 fewer cases of esophageal cancer than gastric cancer. But there is much more attention paid to esophageal cancer, and they're parallel. The pre-malignant condition is intestinal metaplasia in both esophageal cancer and gastric cancer in most cases. I mean, there's squamous for the esophagus and there's diffuse type in gastric cancer, but the majority of these cancers all have a precursor lesion, which is intestinal metaplasia, which results from some type of injury to the mucosa, and it's the body's reaction to that. But if we have clear-cut guidelines saying how to screen, who to screen, how often to screen for esophageal cancer, but we really have, if not nothing, we even have kind of negative information saying, oh, intestinal metaplasia in the stomach actually is not important, ignore it. And this is something that it still goes on today. And I have to aggressively say, no, it depends on the population and what patient. There's so many factors, and people are just perplexed by this. So I think that this kind of gives a relative framework as to what we're dealing with. And I think part of this, again, is political, and this is why you'll hear from Dr. Howard Koh, who was the Assistant Secretary of Health under the Obama administration. This is, I think, the biggest healthcare disparity that exists right now for Asians, and because the majority in the U.S. that get gastric cancer and have intestinal metaplasia are Asians, which is why we're doing this under the Center for Asian Health Research and Education. There are also many minority populations that this affects too, and we want to be inclusive of them as well. But it certainly disproportionately affects East Asians in particular. Whereas esophageal cancer, it's predominantly a disease of older white men in the U.S. who are obese. And I kind of joke, I know this is live stream, but and this will be recorded indefinitely, but it's kind of like what Congress looks like, right? So I think that fortunately that's changing. I mean, and we're excited to see better representation. But this is why we need to speak out, and we need to be aggressive about this. The ASGE does have some buried guidelines, and they're really obscure. I'm sure almost nobody in this room has heard of race and ethnicity considerations in GI endoscopy, which was published in GI in 2015. But I was actually on this guideline committee, and we came out and said we suggest screening endoscopy for gastric cancer in new U.S. immigrants from high-risk regions around the world, such as Korea, Japan, China, Russia, and South America, especially if there's a family history of gastric cancer in a first-degree relative. Most people don't know that recommendation exists. The important thing that we need to understand about the U.S. is, we come from everywhere, and in this era of precision health, if we don't take into consideration the ethnic background and what the prevalent diseases are for these people, we're doing our patients a huge disservice. And so this is just a heat map of where gastric cancer is, and these areas that are in red most likely exceed the threshold and warrant some type of screening because of its prevalence. And I think another thing that people don't realize is that stomach cancer is the third leading cause of gastric cancer worldwide. It ranks somewhere, I think, around 14 in the U.S., so, we do well. Another thing that people don't know is, like, in the 1940s, stomach cancer was actually the number 2 cause of death in the United States. But, with a lot of, H. pylori going away, kind of changes in refrigeration, that has declined precipitously, but it's still in relatively large numbers. Here is the incidence of gastric cancer in the United States. If you look at all races and aggregate them, and one thing that Latha didn't speak, I wish he mentioned this, is this concept of aggregation versus disaggregation. And so if you aggregate the entire U.S. And make this heterogeneous population homogeneous, the incidence is really low, 10 per 100,000. So that wouldn't even come close to anyone's radar in terms of screening. And then if you look at the Caucasian population, it's about 8.9 per 100,000. This is just men. And then the African American population, it kind of almost doubles, about 14 per 100,000, still relatively low. If you aggregate all Asians and Pacific Islanders together, there's actually not much of a signal. It's only 14 per 100,000. And that's because the South Asians, Southeast Asians, a lot of the Asian populations really are not affected by gastric cancer for some reason, probably because of the prevalence of H. pylori in these populations. But now if you look at Japanese Americans and Korean Americans, all of a sudden the signal pops up pretty high. So Japanese Americans, and this includes all generations, so we haven't been savvy enough yet to isolate out which generation. And there was one study out of Hawaii that looked at generations in Japanese immigrants and showed that the first Japanese immigrants, first generation, had a similar incidence of gastric cancer as the native Japanese. The second generation, it was down by half, and by the third generation, it was almost at the U.S. Baseline. So there's clearly something environmental going on. So it's likely higher in first generations or recent immigrants. In Korean Americans, again, including all generations, it's at 52.5 per 100,000. Now, that's actually higher than the incidence of colon cancer. And again, that includes all generations as well. So certainly in that population, these patients should be getting endoscopy for screening. This is also to put things into relative perspective, looking at putting things into perspective with the incidence of colon cancer, which the USPSTF, essentially every society on this planet, has said, okay, colon cancer requires screening. It's a high enough incidence almost everywhere. This is the US incidence by age of colon cancer. This is the US incidence of stomach cancer, so very low overall. This is the incidence of stomach cancer in Koreans and colon cancer in Koreans. So Asians, and certainly Koreans, have a much higher incidence of GI-related malignancies, and so they actually start screening at a much younger age. So they start at the age of 40, and they do endoscopies every 2 years, and it's a paternalistic society. They actually can't get insured unless they have proven that they have done their annual or their biannual screening, because it's so prevalent. And then the question always related to screening is it effective? And that's the number one question that the USPSTF asks if we're going to get guidelines to recommend screening. And there's no it's very difficult to do randomized control studies. And Dr. Hwang, Rob Hwang, the other Hwang, is going to talk. They told him he's got to change his last name. They keep on mixing us up in clinic too. That there's a lot of case-controlled studies. There's a lot of other data that really, I wouldn't even call it circumstantial. It's quite convincing, short of a randomized controlled trial. And I think doing a randomized controlled trial might be difficult. I think it's still feasible, and that might be the route that we choose to go here in the United States. We would clearly need funding from the NIH to do this, and it's feasible. But in Japan and Korea, they're convinced, and what they've shown, so this is 5-year survival of all gastric cancer. And again, as I mentioned before, it's pretty dismal, 26.9% 5-year survival of all comers. Japan, who's had screening for eons, and we have a physician from Japan who'll talk on gastric cancer screening in Japan. They have a 62.1% overall survival, and for early gastric cancer, it's in the 90+% range. So it's kind of like what happened with breast cancer. And when we didn't screen for breast cancer, we had very poor outcomes. As soon as we started screening for breast cancer, all of a sudden, we're detecting very early lesions, and overall survival is substantially higher. And that is completely feasible for gastric cancer. Korea is interesting in that they had national guidelines for screening. They'd been doing screening kind of unofficially for quite some time, and so from 2001 to 2005, they had a 57.7% 5-year survival, and then they instituted national screening guidelines for the entire country, and you saw a 10 percentage bump in overall survival. Many people, Chris, say, well, this could all be lead time bias. You're detecting things earlier and you don't see the long-term effects. But there are studies out of Korea that do show that this is durable, and there is cause-specific survival for patients who have undergone, or for societies that have undergone screening. So again, this shows you the difference between the United States and Korea, stage distribution versus relative survival rate. So a majority of gastric cancers in Korea are diagnosed at an early stage with an over 90% 5-year survival, whereas in the U.S. we only have a small minority of patients that are diagnosed early, and that's clearly because we do no gastric cancer screening. If we find it early, it's luck. It is pure luck. They had an endoscopy for some other reason, usually for symptoms, and we just happened to pick that up. Again, most of it actually here in the U.S., 31 to over 60% is diagnosed at a late stage, and this is where cat's already out of the bag. There's really not even much that Dr. Wu can do in terms of surgical therapy. We're looking at chemotherapy and a lot of palliation. So I want to move on to gastrointestinal metaplasia, because this is why screening works. There's a precursor lesion that we can see. We don't know enough about this, and that's why there's so much debate as to it's nothing versus this is the most important thing that we need to identify. So I think this is the biggest gap, and I think tomorrow we're going to talk a lot about the research that's involved in intestinal metaplasia. But you'll see some other slides related to this, but this is the famous Correa's Cascade, where you have normal gastric mucosa that, when infected with Helicobacter pylori, which is kind of the main instigator of all this, you get inflammation of the stomach, and after a period of prolonged inflammation and lack of treatment, you get atrophic gastritis due to chronic inflammation. That means thinning of the gastric mucosa. That then allows this metaplasia to occur, intestinal metaplasia, which is, it's a healing process, right? It's a reaction to damaged mucosa, and it's trying to re-epithelialize, but it does so with intestinal metaplasia, which many consider a pre-neoplastic process. And then from this point on, we pretty much feel that this is irreversible once it gets to this atrophic state in intestinal metaplasia. This is where the disagreement occurs in the United States, because not all patients develop atrophic gastritis but still can have intestinal metaplasia, and they're just small foci of intestinal metaplasia. That probably isn't an increased risk to go on to gastric cancer. What we're talking about is diffuse atrophic gastritis and extensive intestinal metaplasia. And if for patients who have that, usually resulting from chronic H. pylori infection, those patients, a reasonable proportion of those patients will go on to dysplasia and then cancer. So the idea is to, the true idea is to prevent it here. I mean, that's prevention. But the cat's out of the bag for many people already. So now we have to think of how we can prevent progression to cancer. So that's where screening and surveillance come into play for atrophic gastritis and intestinal metaplasia, to identify dysplasia early and remove it, or address neoplasia. For time reasons, I'm actually going to skip this. I think other people will talk about this. I do want to mention this racial distribution because I think it's an important reason here. So we did a retrospective study when I was at the University of Washington, where we looked at all endoscopies that were done from 1999 to 2014, and there were over 36,000 endoscopies performed. And this basically demonstrates the racial distribution or the ethnic distribution of the Puget Sound area. Majority of Caucasian, but there's a good percentage of Asians, Pacific Islanders, African Americans, Hispanics. We then looked at who had intestinal metaplasia, and there's still Caucasians do have intestinal metaplasia. We don't know what the extent of it was because, again, we're not able to, this was just a retrospective study, but there was a disproportionate number of people who were of Asian or Pacific Islander descent. And if you looked at the overall prevalence of intestinal metaplasia, 5.7% of the population had intestinal metaplasia on this retrospective study, only 3.2% in Caucasians. But if you looked at Hispanics, 11.5% of Hispanics that had endoscopy had intestinal metaplasia, and 23% of Asians who had endoscopy had intestinal metaplasia. And this kind of correlates to like the incidence of cancer in these groups. So there is almost a 10-fold increase in incidence of gastric cancer in Asians compared to the Caucasian population. This is another study that we did based on the UW cohort, and we found that the odds ratio of developing gastric cancer was 9.3 if you had intestinal metaplasia. So very strong signal, and actually of East Asian descent. So that included Japanese, Koreans, Chinese, Mongolians, and Vietnamese. You had a 15.9 odds ratio of developing gastric cancer compared to the Caucasian population. And if you were of other Asian descent, it was actually only down to 2. The odds ratio was down to 2. And then these were weaker signals, even H. pylori infection or tobacco use. So there is a very strong signal in the Asian population for developing gastric cancer. This is just another way to couch things. In patients who had cancer, so these are the cases, a majority of them, especially in the Asian group, had cancer in a background of intestinal metaplasia. So that it's a bystander effect potentially, but that does implicate intestinal metaplasia as a precursor lesion. If you look at people who don't have cancer, so our controls in Asians, and these only include ones who had biopsies. Of Asians who had biopsies, of the East Asians, 41% had intestinal metaplasia. Again, it's highly prevalent. I'm going to skip this because I think it'll be discussed later, and this is also discussed in another one. I just want to quickly show you what intestinal metaplasia looks like. So this is white light endoscopy, and then we have narrow band endoscopy that allows us to see better. And you can see this is a lesser curve of the stomach. This is all atrophic gastritis and has intestinal metaplasia embedded in this. Over here to the left, that's what normal mucosa looks like. So you can see there's a really sharp line of demarcation, and that really correlates to the distribution of H. pylori infection as well. And so we can see this endoscopically. And I will tell you that one of the reasons that we didn't do much of this in the past is we were a little bit nihilistic as endoscopists because we didn't have good imaging technology. So this is, relatively recent imaging technology, and it's just getting better. So we can see more, and so I think our screening is better. Dr. Chung will kind of talk about this, so I'm going to skip over these images. Again, this is an example of imaging getting better. This is something called near focus imaging, where this is intestinal metaplasia on endoscopy, so we can see it quite well. Again, the ASG has another obscure guideline about suggesting surveillance endoscopy for patients with intestinal metaplasia who are at increased risk of cancer due to ethnic background or family history, but we don't really know what the intervals are. And the real goal is to identify early gastric cancer or high-grade dysplasia and remove it when feasible. So I'm going to kind of skip over this because this will be discussed by other speakers, and I want to kind of this is I was talking to Dr. Ko, and this is why I think there's all of a sudden it's a big interest in the GI community about gastric cancer, and it's because everybody wants to do this new technique, and it's called endoscopic submucosal dissection. And it is kind of the frontier of endoscopy. It's where we become surgeons and we cut. We can resect out early gastric cancer. And so these are just images of this resection. Many people want to do it, but the main indication is early gastric cancer. We do it in esophageal and colon as well, but the primary indication really is gastric cancer. And so people are now interested in this concept of screening for early gastric cancer, which I think is great, and we need to ride this momentum. Dr. Wu, I think, will talk about ESD versus surgery, so I won't go into that. And I just want to conclude with this. What? Yeah, it's good. So anyway, so this is my last slide, and it's really who is at risk. And what I like to show is that, again, people come from all over the world, and many immigrants still are part of the community here, and we need to acknowledge that. We need to recognize that. We need to know what their risk is, and we need to treat them appropriately and do what's best for these patients. And we clearly need to do more and not take a nihilistic approach and just say that it's not our problem, because it is our problem, and there's clearly things that we can do about it. So, take-home points. High risk. We have a high-risk population in the U.S. A premalignant condition that can be screened for and surveyed exists. We have no guidelines on gastric cancer screening in the United States, and we need them. We have early high-grade dysplasia, which is the precursor to gastric cancer, as well as early gastric cancer. We can manage that endoscopically without Dr. Wu. We can put her out of business or make her do surgery of other stuff, and preserve the stomachs of patients. Nothing personal. And I think she would be more than happy if we achieved that goal. So the bottom line is we really need to work on improving outcomes in gastric cancer, and prevention and early detection really is key, and that's the goal of this summit. So I appreciate your attention, and with that we will move on to the next speaker. Go ahead and come on up. Next speaker is Dr. Yang-Hee Wu. I've met her a couple years ago. She is a storied, probably one of the most famous gastric cancer surgeons in the United States. She trained at Columbia and did her initial career at Columbia, and then they wooed her to the West
There are
Coast.
very few gastric cancer surgeons in the United States, and I could be out of a job soon.
But our goal is to not put her out of a job, but to have her work on some other stuff. So without further ado, I'd like to welcome Dr. Wu. Thank you.
Thank you, Dr. Hwang.